So what we'll be covering is the time is now, and a little bit about why. You know, why is it so uniquely different today than any other time in our history? Health IT is the means, not the end. In other words, we're using it to get to the end. You know, sometimes I think, well, myself included, when we do implementation, it's so hard. And so when you get to the end of it, you're like, oh my God, I got it in. And you feel like you're done and you can move on. But quite frankly, that's the beginning. That's not the end, right? Because what we want to use is the technology to actually make a difference in patient outcomes. And that's the part that's actually hard sometimes to mine out. And to remember that it isn't about this hard work of getting it in. It's about the hard work of making it valuable and doing the things with those tools that we know we need to do to revolutionize healthcare in the United States. So just a little bit of history. I like to go back to this because President Bush did start this off back in 2004. In his State of the Union address, he's the one who got this whole thing started and said, an electronic health record for every American by the year 2014. By computerizing health records, we can avoid dangerous medical mistakes, reduce costs, and improve care. Now, those of us who were working in IT at the time were like, oh my God, I can't believe that a president, you know, in a huge national forum, went ahead and called out health IT. And that was really the first time. Now, when we talk about the money related to the American Recovery and Reinvestment Act that was given to health IT, it's a good chunk of money, okay? Well, depending on whose numbers you count and what we actually end up getting, it's between $20 and $30 billion. So it's really a lot of money. But if we come forward now to current time, in 2009, just after he took office, in his first weekly address, President Obama said, to lower health care costs, cut medical errors, and improve care, we'll computerize the nation's health records in 5 years, saving billions of dollars in health care costs and countless lives. Now, it doesn't take a math major to realize that this was a bipartisan issue, okay? Because in 2004, President Bush said 10 years, and in 2009, President Obama said 5 years. And so that goal, if you will, of 2014 has really stuck. And if you look at the stimulus bill, the High-Tech Act, that becomes a very important time because that's when the penalties actually are beginning. Now, what was different between the two presidents, of course, is that more momentum had been gained, and in 2009, of course, the American Recovery and Reinvestment Act was passed. Now, there were other things going on, and this is just a representative sampling of some of the other public things that were going on. There were some federal government things going on in terms of research related to safety and the lack of safety, actually, in some of our healthcare practices. And then there was also some things going on in the public. And so increasingly, we started to hear about, medication error that caused problems with infants. We heard about statistics in healthcare in general, in terms of you're better off not going in the hospital and staying home because your likelihood of getting a complication, infection or something when you get into the hospital is a problem. And so, again, representative sampling of some of the press things that were also causing health IT because it could be a solution to some of these issues to actually start coming to the forefront. And there's one other reason that the time is really now. So we have the federal government stuff, we've got increasing both political and private pressures, and even in some cases patients starting to say, gee, I didn't realize this was so bad. In addition to that, technology was finally catching up. Now, I'm going to show you. I did my first bedside, and that's definitely a quote, bedside documentation system in the early 90s. So think back to that time, early 90s. Yes, you are correct. We did not have wireless. We did not have flat screens. And quite frankly, that was what we came up with for the nurses. So that was the boat anchor cathode ray tube. Did not have a battery. The power and the network cables came out of the ceiling. And the nurses said they wanted something that they could push out of the way. This was in a recovery room area, post-anesthesia recovery room area, and then pull it back down. Sounded really good when we were meeting with them, and yeah, it lasted about an hour. So then we came up with, literally, if you can imagine building this thing. Our environmental services folks were like, you got to be kidding me. So then we stole a respiratory therapy cart. This is definitely a precursor to the computer on wheels, because again, you can see no flat screen, no battery, because the batteries just didn't last long enough. The power came up through the ceiling, and the network cable came there too. We've come a long way, and these are the kinds of things we had to deal with then. And I mention this because in healthcare, it's extremely important that we always think about this interplay between the people, the process, and the technology. So I talked about the technology. You get the wireless, you get the handhelds, you get the flat screens. That's really kind of pushed us. But it's that use of the technology within the workflow that's actually going to make the difference. And that's why the form factor that you use becomes so important, and how it does or doesn't help with the interaction with the patient, and how easy it is to log in and to log out, and how easy it is to navigate the system itself. So when I think about the systems that we have today, we have options. We've got different kinds of capabilities in terms of the way we can use our form factors. A lot of the vendors have not only put out software that runs on Windows, but they put on applets that work with those that can be taken into the room for medication administration, for example. And so, I think we're going to continue to see that, but we cannot underplay how important that has been to our evolution of where we're standing today. So yes, I give a lot of credit to the federal government in stimulating, and when you see some of the statistics, you'll see why that's so important. But there's also been a lot of industry things that have caused us to be where we are today. So the High-Tech Act had a bunch of programs, and this is a chart from actually an article that Dr. Blumenthal published in the New England Journal of Medicine right when the first stage 1 criteria came out for public comment. So it was December 30th, 2009. And it did a nice job of harmonizing the different programs. So, down the left-hand side, you see the regional extension centers, the workforce training, etc., and how those feed into the meaningful use. But the important part of this slide is not stopping in the bolded meaningful use box in the middle. It's going to the right-hand side and talking about how we're going to use meaningful use to actually drive modernization of healthcare, to actually drive healthcare reform, to drive the changes that we know need to occur in this space related to how we provide care and how we pay for care. So we've had a remarkable journey already related to meaningful use. Actually almost unbelievable. And so let me talk about that a little bit. One of the things that we've been looking at the ONC is the fact that though meaningful use has been going really well, that we had to put a bit more attention on it and really look at 2012 as the year. So meaning that the criteria are now more understood, the vendors have gotten through making sure all their software is locked and loaded, they've read all the frequently asked questions for both CMS and ONC, they put the little fixes in that they had to put into their initial code that got certified, and we're really sitting in a pretty good place. So this is the year of meaningful use. And when you hear just about anybody from ONC talk, you're going to hear about two priorities. One is meaningful use acceleration, really making this be the year of meaningful use. And then secondly, really pushing the idea of health information exchange. That we actually have to start doing this. We've got to get good case examples. We've got to get good use cases and demonstrate that we can do this. And so it is one of the things, or two of the things, I'm looking for you all to help with. Get your folks to meaningful use, or if you're a meaningful user yourself, continue. And secondly, help us come up with some really good examples of health information exchange so that we can proliferate those examples, disseminate them, see what works, what are the good ways to implement, what are the good business cases or value propositions for health exchange, and so we can again start to disseminate that around the country. Health exchange is so important when we think about that patient-centric record and the ability to actually move the information as the patient moves, or maybe we're not really moving the information, but we're having it accessible as the patient moves. Extremely, extremely important. And we've been living the way we've been living for so long, Sometimes it's almost hard to imagine having it any other way. A patient doesn't think twice about going to a physician's office and filling out a form on a clipboard and going across the hallway to have a radiology exam and filling out a form again. That's just how it is. That's how it's always been. Now, I'm just talking about demographic information. Though important, and though that will help us move things along, we really need the clinical information to move with the patient. So that anywhere that patient is seen, we know who they are, we know what their allergies are, what their problem list is, what their history is, their personal history, their family history. And imagine, again, how different care would be if everybody had that medication list when they were dealing with a patient. And so those are the kinds of things we talk about with Health Exchange, is that anytime, anywhere, ubiquitous access to the information about the patient that you need to care for them. So I got off a little bit of Health Exchange, back to meaningful use. So Farzad, when he put together his blog in January, talked about these two priorities and talked a fair amount about how we need to accelerate meaningful use. So let me give you some statistics. Look at where we're at. And these are statistics through March, and this is the number of, let me make sure, the number of participants. Yeah, this is the number of people who have been paid, either through the Medicare or the Medicaid program. So the number of people who have been paid. And our total is 76,000. Now, some of you may know this number, but when we put out the Meaningful Use Acceleration message at the beginning of the year, we got together with CMS, so we had to dicker a little bit about what our goal was going to be, but we set a goal for 2012 of 100,000. It's looking pretty good, isn't it? And so as of March, we're already at 76,000. Well, again, some of you maybe know Matt Kendall. Matt's the director of OPAS, which is the Office of Provider Adoption Support. He's the one that runs the regional extension centers and is pretty much responsible for the dissemination of best practice related to implementation. And as Matt says, you know, we're going to blow this goal away. It's going to be 200,000. However, like you all in your employment situations, you probably have to set annual goals. Well, our goal had to go to the White House, and people were a little worried about putting in the 200,000. So they put in the 100,000, and it does look like we're definitely on track. And you can see the monthly kind of hockey stick curve going up to the right. And how, you know, we started to creep up in fall, and then really got going in December and January, February, and now March. So we're extremely excited about these numbers. And when you look at it, again, these are the payments, the total payments made. We are now at $4.5 billion being paid out of the total. So we're starting to really accelerate like we wanted to and are excited about these numbers. And then if we look at the state numbers, these are provider state numbers. You guys are doing really good. So this is a normalized number. And the normalized number basically took the denominator being all of the providers in the state and the numerator being those who had already been paid. But I think, you know, the challenge has been set. We'd love you guys to be number one. There is actually a state challenge out there. And we haven't decided exactly what the prize is going to be. I can guarantee you it won't be money, other than the money that you're already getting. After the GSA fiasco, we had to take those gold medallion coins and return them. Oh, and the bikes. We were going to get bikes too. Just teasing. But the recognition alone, but we are going to have some kind of little prize of some kind. We just thought we'd start to think about that. But over the states, the highest again is 21% and the lowest is 1%. And so you can see you're really sitting pretty, and I think it'd be pretty easy for you to knock off those top three and get that spot. So again, I throw that out to you. Okay, so this is the eligible hospital payment. This one's a little bit harder to read. The Medicare and Medicaid. You probably know that for the hospitals, you can actually get paid from both. So you can apply within the state for the Medicaid money when you're in the hospital space, and then you can also apply for the Medicare if you're meeting the meaningful use criteria. And so there is some duplication between these numbers, meaning the same site could be in the numerator of both numbers. Okay, so what's happening in the industry with our electronic health records as well as with the implementation? This was very interesting information that I thought might be helpful to share. The American Hospital Association survey data, the 2011 survey was done in fall of 2011, so this is maybe 6-month-old information. And what's interesting about this is, again, this hockey stick curve. So this is hospital data, because it's the American Hospital Association, reporting how many people, and they self-report for this particular survey. If we look back to 2008, about 15% said they had at least a basic electronic health record. And of course, a basic wouldn't have CPOE, and it wouldn't have clinical decision support. But look at that number today, and how high it's gone up to 35%. Rural lags a little bit behind that. Okay, so the basic in rural is the red line, and you can see again there's a gap between rural and urban hospitals, but again, the hockey stick curve. And then if you look at the comprehensive, that also has doubled from 2008 to 2011. So we're definitely looking good. Now, how many people are familiar with HIMSS, the Health Information Management System Society? A good chunk. Okay, so that's an IT organization that many of the hospitals belong to. Probably in the provider space, there's some folks that participate, but it's a professional organization, and it does have 38,000 members, so it's a pretty large organization. And they have a staging from stage 0, and that's represented here at the bottom, to stage 7 in the hospital space again, for the maturity of the adoption that's taken place at that site. So it has to do with implementation, but it also has to do with adoption or use, similar to the meaningful use criteria. So if you look right here at the Q3 and Q4 2011 data, you can see there's a clustering of 45% or so above stage 3. And if you look, it's about 28% of the hospitals are above that, and about 27% are below. So it's a true median as well as being, the average. But what's interesting to look at, if you just go back to Q1 and Q2 of 2011, you see again about that same midpoint. But if you look here, there was 23% above and 32% below. So how that's actually shifted from the bottom to the top in maturity in just really a 6-month period, from Q1, Q2 2011 to Q3, Q4 2011. So again, I think these are really signs that people are not just getting the products in and doing the implementations, but that they're also actually getting to the adoption as well. So kind of wrapping up on meaningful use, there were priority goals that were identified from the National Patients Priorities that the meaningful use criteria were actually based on. And if you recall looking at the criteria themselves, almost every time you see the meaningful use criteria listed, they're grouped along these 5 overarching goals. So again, important to remember that it really does harken back to patient-centric outcome kinds of goals and not implementation goals. And then you'll recall that we talk about maturation of criteria from stage 1 to stage 3. And oftentimes there's an arrow diagram used, but basically the building blocks infer that at stage 1 we're getting it in, and at stage 2 we're using it to actually start to measure quality, and then at stage 3 we're actually going to be looking at the outcomes that are changed as a result of having the technology in. And so this is going to be an interesting time going between stage 2 and stage 3. Because again, we're going to be upping the ante, I think, as an industry, as a healthcare industry, as to what we're really looking at as we start really trying to get an outcome measurement at stage 3. Now when we take this and think about this meaningful use of meaningful use, and what I mean by that is the concept that we take the opportunity to use this journey to do the right thing. So this isn't just about checking the box and making sure you meet the meaningful use criteria. The meaningful use criteria are a floor. Okay? It's the minimum of what you should be doing. What you need to do is take this opportunity, not just to use the money in the implementation, but to use the energy of the people who are doing it to actually link these things to doing the right thing for the patient. Looking at quality improvement, looking at outcome improvement. Even though The government hasn't mandated that we need to be doing that yet at stage 2. Using this opportunity to do it within your own organization makes sense. And don't make it just about, we got to get this in so we can meet meaningful use and we can get the money. Yes, all true. I mean, I'm with you on that. But you also want to make it about making sure that you're changing care in a positive way as you're doing that. And so there's other initiatives that are going on. Again, stage 1 was fairly low. Stage 2 is up in the ante a little bit. But when we start to think about leveraging stage 2, that's where we start to think about things like patient-centered medical home and how we can use the concepts and the implementation of a patient-centered medical home to drive some of those same goals and to leverage the things that we've done at stage 2 meaningful use. And then the 3-part aim. Okay, what's the 3-part aim? Better health care, lower cost. Again, keeping that in the forefront of everything that we're doing and making sure that we're thinking about the health of the population, the health care that we're giving to the people that are in front of us, and then making sure that we're considering the cost equation. Of course, all the changing payment models are coming with that, and they're all really wrapped around the idea that it's not just providing care to the patient that's in front of you. Around the idea that it's not just providing care to the patient that's in front of you. It's considering the patients that aren't at your door. It's that concept of who aren't you seeing, okay? That patient that doesn't come for their preventive care, that doesn't do the healthy habit stuff that we all should be doing in terms of eating and exercise and things. How do we get at those people? And that's a really good example of something that almost can't be done in any way when you're on paper. But you can start to do it when you've got a computer database of patients who are on your panel and you have a patient-centered medical home. Okay, so again, really important to think about where are the gaps in the healthcare and not just focusing on providing the best care of the patient that's in front of you, but making sure and thinking about all those patients that aren't in front of you, which really gets us to the accountable care organizations, the bundled payments, the way where we're incenting people to look at the health of a population and reimbursing value-based care instead of reimbursing the use of healthcare facilities and the use of supplies, okay? And that's where we're going to be going with stage 3 meaningful use. And that's when you hear us at ONC talk about meaningful use and meaningful use, that's pretty much what we're talking about. And overarchingly then, that's taking this idea that we're using technology at those lower levels to gather the information. Then we're actually improving access to that information. And when you improve access to information and you have better data, you make better decisions. And that's the concept there in the middle. And then, of course, if we're making better decisions and knowing everything about all of our patients, we're going to actually be able to do this transformation stuff that we keep talking about. And again, that's pushing to that stage 3 stuff. So kind of wrapping up then, thinking about, again, the 3-part aim. Health information technology is really the infrastructure that's going to help us look at the better healthcare, better health, and reducing costs. And it's really going to drive, again, where we know we need to be going in healthcare. Just some examples of how Health IT does that. You all probably have many other kinds of examples. But hardwiring evidence-based practice through order sets and through care plans, clinical decision support, documentation templates, the way we display information in flow sheets, facilitating access to information during encounters and between encounters. Again, that idea that you collect the information once and you use it many times and you make sure that information is available across venues at all the different points of care. Involving the patient. I didn't talk about that today as much as I would have liked, but the idea here is not, again, to get the patient involved in the technology because it's cool. Well, that's true, of course, but the purpose here is really to start hooking the patients in the idea that they're a partner in their care. And this is our untapped resource. I had this visualization. Actually, it's kind of funny because my mom's been in and out of the hospital. And, I kind of picture one day her saying, and she's 85, so I'm not sure she'll ever actually say this, but as she's being discharged, going, now, excuse me, but who's going to do my medication reconciliation? And what kind of pressure that would create in our healthcare organization. You know, just getting the med list right. You know, I go back 10 years ago and, you know, I'm thinking, I don't even know what patients did. You know, did they fend for themselves? You know, they came into the hospital and they had allergy medications or whatever, and they had, you know, orthopedic surgery, and they went home and they just figured it out themselves, I guess. I mean, when you think about it, that is just so basic, but it's not something that we consistently do. So getting the consumer involved in that, where they realize the med list is really an important thing, and they make sure that it's right. And they make sure that if something's on their list, that they're actually taking it. And what a difference that would make in healthcare. And again, if they have easy access to that, they're more likely to get involved in it. And so again, this isn't just about getting a personal health record because it's cool to have one, but it's about the way that that hooks you into actually providing input and being a true partner in your care. And then, of course, population health management and our ability to do public health as well as surveillance.